Welcome everybody who's able to attend live to our webinar. Today we're talking about how the heads and beds revenue model is dead, talking more about the need for quality over quantity. As always, this webinar is recorded, so I will be sending out the recording afterwards to everybody that attends, and then anybody who doesn't attend that wants a recording, I'll send it out too. Today, we've got some awesome people on board, and I'm not just saying that because one of them is my boss, but we've got Chris Wolfington, who's the founder, CRO, and CSO at FinPay, and we've got Umberto Bugnotto, who is the CEO here at Opus. I'll let you guys introduce yourself. I'm going to hop off camera, but I'll be here mitigating the Q&A, and again, we'll do Q&A at the end, but feel free to ask questions throughout. I will interrupt these guys, but turn the time over to you.
Can we swap our pictures so everyone thinks I'm the better looking guy?
I was just going to say, just for the record, I've been envious of Chris's picture for a long time because he's got the bow tie and very few people can actually pull it off. I see this guy at the conferences and I'm like, I could never pull it off. So I had to get a new headshot for this webinar just to be a little competitive. I think we're like close, but you're still pulling ahead, I think.
I don't know about that, but I'm glad to be here. Umberto, always nice to talk with you.
Yeah.
I look at all my titles. So that's Chief Revenue Officer and Chief Strategy Officer is my day job over at FinPay. And I'm glad to be here. So thanks everybody for taking the time out of your day. I think it's a really timely conversation that is way overdue in my opinion. But I'm looking forward to dive in.
Yep. I'm the CEO here at Opus, been with the company over 10 years. When we were just getting Opus off the ground. Some of you may not know, but we come from the operator side. We started and scaled several behavioral health organizations over the first 5 years of Opus. So we were essentially their operating system, and we then decided to sell Opus as a product around 2018. So we have a deep expertise into the operator space. We know exactly what SUD and general behavioral health operators go through. And what we're going to be talking about today, I think, is very relevant to operators in the space.
So today the notion is challenging. It says a legacy business model, but I'll say a dead business model and how you can move forward. And the idea is, and I'll go through the agenda right now, is really just how did we get here, right? How did the heads and beds model come about? Why did it last so long? What are the limitations of it? And why in the current environment, it's just not sustainable. It's not just sustainable in the context of, oh, I might make a little less money. It's an extinction level event where companies will no longer be able to operate and they will see their cash dry up like the Sahara Desert if they continue with that model. But if you don't mind just moving ahead and we'll sort of go through how we're going to tackle this conversation. Let's talk about how we got here. So the traditional behavioral health model, and we're just going to be real blunt here and have just a real honest conversation. 10 years ago, regardless of what part of behavioral health you're in, the reimbursement rates were high enough. I'd like to say so high, but let's just say high enough that nobody cared what the patient owed. In fact, this graph right here is looking at a traditional inpatient model back in 2015, where you could generate $22,000 of revenue, of which, excuse me, of which 98% of that revenue was owed by insurance. And so it never made sense to talk to the patient about the $500 or $600 they might owe because you'd never want to alienate that patient. And the logic where heads and beds came from was if I could just get the head in the bed, the money will take care of itself. So admission teams were sort of trained, close the admission, close the admission, close the admission. Don't talk about money. Just validate that they have an active insurance plan and get them in the door. And then the financial people on the back end will count up all the money that we bring in once the claims are adjudicated. And I'm not naive. That model worked for a long time. And if you were at a network, that 22,000 was like 30, 40, $50,000 for an admission. And so it made a lot of sense. But what happened was, in the course of the last 10 years, several factors have changed. Number one, fundamentally, rates have come down. That's just a fact. I personally think a lot of that had to do with COVID. I think the insurance companies never paid attention to their behavioral health portfolio. That's why you have carve-outs and all that. They didn't even care. And then what ended up happening was they were like, wait a minute, we're paying $4,000 for a day of detox? Like who approved that? So overall, rates have come down. The out-of-network model has been systematically under attack. Payer audits have increased. Claim clawbacks have become more frequent. And at the same time, if all those things weren't bad enough, there was a major cost shifting change where high deductible health plans came, even though they started back in Obamacare, the Affordable Care Act, they accelerated over the last 10 years. And now literally 25% of the revenue of any behavioral health organization is owed directly by the patient in the form of deductibles, copays, coinsurance, or private pay customers, right? But the industry is completely ill-equipped to manage that part of the revenue they're owed. So now you're 100% heads and beds has a tough time working, right? Just getting the patient admitted is not in any way, shape, or form mean that you're going to get paid enough money to cover your costs. It also creates more manual work for everyone in the organization across all the departments and less revenue for the business. So what I mean by that is, if I just get the patient admitted, well, now the patient owes 25% of your revenue. At some point, somebody's got to deal with that. Is that the back office staff? Is it the facility staff? Does anyone admissions try to collect any money? If they do, if you're using, not to give Opus a commercial, but one of the things I love about Opus is their CRM capabilities and their electronic medical records capabilities. Everything is seamless and translates across from admissions into the facility, into the clinical care, so you don't skip a beat. But there's still a lot of people out there that are working with disparate systems, like they use a different kind of CRM that connects with a different kind of EMR. And so what happens in admissions, nobody can see that at the facility, and no one in the back office can see what the facility and the admissions did. So it creates this chaos that makes it impossible. If you're a CEO, a CFO of a behavioral health organization, all of a sudden 25% of your revenue is owed by the patient, and you have no automation and no means by which to even see how much you're owed or how you're going to get paid. What are you getting paid? How do your patients prefer to pay you? None of the current systems out in the market. So all of a sudden you're finding out that a decision made in the admissions department was a really bad decision, but you're finding that out 60 days, 90 days after the patient discharged. I mean, there's literally nothing you can do about it. And there's no visibility into knowing what the problem was. So you can't even go to the admissions staff and say, hey, do this differently or do that differently, because the heads and beds model, where everyone is just trained and all the KPIs they're measured by are get the person in the bed, get them in the bed, that does not assure profitability.
Not to jump in here, Chris, but I'm definitely cutting out that part and saying, hey, this is our new commercial for Opus. So just kidding. But yeah, I appreciate what you said. Obviously, data is huge. Like you said, if you don't have that visibility cross system, like how are we able to make those decisions and make sure that you're not missing that billable stuff 60 to 90 days in the future?
Yeah. Okay, then there's another slide that sort of articulates that. The next one, I believe that. Well, I was talking about organizational chaos, and I'm sure, Alberto, you guys see this when you're doing your onboarding and whatnot, and one of the reasons why automation is so important, right? So I'll give you a couple simple things. Heads and beds motivates admission staff just to get the admissions, yet the decisions they're making single-handedly determine the profitability of the business. And very few people align the KPIs of the admissions team with the KPIs of the organization. And so the incentives that they're measured by don't align with the organizational sustainability. And then a lot of times, patient financial responsibility represents 20, 25% of the revenue. All of a sudden, that's pushed onto the facility staff. So here's facility staff, almost by definition, are caregivers, right? That's where your clinicians reside. That's where the administrative people reside, right? And all of a sudden, they're now burdened, tasked with trying to manage, with no automation and no systems, all these clinical and financial engagements. Clinical is enough all by itself. I mean, most people staff their organizations to meet their clinical demand, but now all of a sudden you know tap on or add on all the financial engagements with the patients that are necessary, and not even from an economic standpoint, but from a compliance standpoint. The single biggest successful way a payer claws back a claim is through inducement violations. It's the number.
I love talking about that. I that's something that I think a lot of people on the webinar are going to be kind of surprised to hear, because it'd be surprised how many customers we talk to, how many prospects we talk to that just have no concept of what you're talking about.
And if you have, and here's why that is. Like if you're a customer, this is Opus, so I'll say that. If you're an Opus EMR customer, your clinical notes, the parts of the system that are designed to make sure you get paid by the insurance company are buttoned up pretty tight, right? I mean, Opus has come up with a lot of things in a lot of features and functionality to make sure that not only are you able to automate the care and the notes and make it more efficient for the staff at the facility, but it's also helping the revenue cycle team make sure they can code properly and get paid properly, right? So unless someone just does a really bad job of you know, the clinicians and the work and the charts are really sloppy, which is not the norm, the payers go to where they think you're most vulnerable. There was that big Aetna lawsuit. They sued 9 treatment facilities for $250 million, going to claw back 5 years worth of claims. And 4 of their 6 arguments in that lawsuit were around inducement. Oh, you weren't doing good faith estimates. Oh, you weren't collecting out of pockets. Oh, you weren't and so all of a sudden the first reaction most people have is, oh, I'll have my facility staff do it. I don't want it to get in the way of the admissions. Remember, heads in bed says, just get them in the door. Don't worry, the facility staff will handle it. Well, there's just not enough time in the day for them to handle that. And plus they're not trained on that. And personally, I just think that's an unfair way to tackle the problem. And then the poor billing team, I don't care if it's a third-party biller, an in-house biller, I don't care if it's just someone in the accounting office. That person, their basic fundamental duties that are core to the business are completely interrupted, and because everybody else punted the responsibility. And now they're dealing with patient calls. They're dealing with patients going, well, they told me this. They told me that. They told me I only had to pay my deductible. They told me I didn't know anything, right? And I always say, who's they, right? If I'm that poor back office person, I'm going, the famous they're armed with nothing to defend the organization around what the statements the patient is making. And then you become a collection company. And there's a whole other webinar we could have, Umberto, about the value of alumni and creating a good financial experience. So if alumni relapse, they come back to you, because nothing is a brand killer worse than a bad financial experience that aggravates an alumni.
Well, I have recent personal experience with the day that you're referring to. My wife had a procedure 5 months ago, and to this day, without fail, every week we get a random bill from some random provider, a lab or a doctor that was under the hospital that she was at, or some anesthesiologist, or some specialty, and we just got a bill. Never discussed. We're told this is what you're going to pay. You go to the desk, you say you're going to do this, you pay your deductible. It's $100, whatever it is. That's it. You think you're home free, but no. And I've spent hours on the phone myself trying to figure out, like, why am I getting all these bills? And of course, their explanation is always never clear. And now I have, as a customer, because even, in healthcare, you're a customer too. I'm never going back there. I'm going to have to try to find another place. So they lost me as a customer just because they weren't upfront about what I'm going to.
You want to hear an absurd statistic? The average patient financial, the patient satisfaction score on the financial experience in all of healthcare is less than 5%. So I think, and I have data to back this up, but this is the basis by which I started my company. The organization that puts their hand out and says, I'll help you. I'll help you navigate this. So take how you just described that. And you had, you mentioned 3, 4, maybe 5 different organizations are sending you bills. Imagine one of them has somebody on their team that says, hey, Umberto, I got your back. I'm going to help you navigate this. That's your hero. That is the brand builder, the organization. So heads and beds is dead. If you're still running an organization that revenue model is get them in the door and everything's going to be okay, I'm just going to tell you right now, your organization suffers, the patient suffers, your business, I'll give you 3 years until you're out of business. It's an unsustainable model. And, if you think about fear and anxiety around costs, what's interesting about behavioral health, unlike any other part of healthcare, two interesting anecdotes. Number one is it's the only part of healthcare where even though you really need the service, you still have to convince the patient to get it. Like if I broke my arm, I know where I'm going. There's a hospital 10 minutes down the road. I'm going there and I'm going to get a cast on there. No one has to convince me to go there. But in behavioral health, there's a lot of options. Most consumers are uneducated in how they, differentiate between behavioral health organizations. So you still got to convince them. That's why there's admissions departments, right? And so when people have fears and anxieties around cost, and they're not stupid, it's 2025, people know they owe money. When they feel someone isn't being transparent and upfront, or they have all these fears and anxieties, they're going to go to the organization that relieves them of that fear and anxiety, right? And then if you're just about getting the admission, getting the head in the bed, it's almost impossible in 2025 and forward to run a profitable program and also to, shelter yourself from inducement compliance risk unless you really treat your entire revenue stream holistically, not just insurance. And then just to be a good boss, staff burden. Like it makes no sense to try to manage 25% of your revenue with paper and spreadsheets across multiple departments that can't see what the other department's been doing. It makes no sense. I mean, imagine if you're an Opus customer and someone came in and says, "Oh, you don't need that. You don't need an EMR. It's easy if you do it by, use paper and spreadsheets, no problem."
Yeah.
Like they'd be run out of town. Like that's just an absurd thing to say.
It'd be like
EMRs
going back to paper charts.
Yeah, it's people would laugh at you. They wouldn't even take you seriously for even suggesting it. But the question is, 25% of your revenue is still being managed by paper and spreadsheets, and that kind of makes no sense whatsoever. So now let's talk a little bit about, I think we're jumping right into the, what can you do part, right? So I love this tagline. Quality is the new quantity. Quality of census over quantity of census. Tracking where your leads are coming from, the type of patients, because keep in mind, I don't care how good your admissions team is, they cannot make the phone ring. And I also don't care how good your admissions teams are, or intake teams. They can't control when the phone does ring, who it is on the other line, right? So they manage what they get. And so being able to have visibility into the quality of the potential admission leads that you're getting is crucial, right? You can use, I always found this interesting. Organizations have a marketing strategy and they have a marketing budget and they deploy that same strategy and that same budget month over month, but they get wildly different results month over month in terms of admissions. And nobody can explain, the CEO, the CFO goes running into the admissions center and we go to the director of admissions, like, what's going on? Why is census down? And the poor person that's in charge of admissions, like, I have no idea. The phone rings, we answer it. We trained our people to do this. We try to get them admitted. I have no idea why census is down. But they say a lot of things and they respond because their boss wants to hear an answer, but they have no idea because they don't control the phone to ring and they don't control who's on the other end. So having the ability to understand and visibility into the quality of your potential census and the ultimate admissions that you approve over quantity. Because think about it, quantity in 2025 can be a double negative. You literally could grow your census, make less money, cause more chaos for your teams, more burden on the clinical teams, and make less money. And this is why I always say to people, like, you need a robust CRM. You've got to have a CRM that really not only has the ability to track the leads, but also tells you where those leads are coming from, where are those channels, that track not only payer mix of who you admit, but payer mix of who's calling. Right, Umberto? This is one I say to people all the time. You can
So
look
when
at
the CEO and the CFO can just look at a screen instead of running into the admissions office and asking what's going on.
yeah. Well, and not only that, how many times, like, have you seen where somebody goes, "Oh, I know what my payer mix is. It's this much Medicaid, this much in network, out of network, these exact payers, right? Whoever, Aetna, United, whoever." But that payer mix may have been totally different from the people that called, right? So let's say I get 100 phone calls and I admitted 10 people, right? My payer mix of those 10 might be completely different than the payer mix of the 100 that dialed in. Right? And being able to see and understand, because your marketing strategy and your marketing budget is attracting a certain type of patient, whether intentional or by accident, and being able to see who it is that's attracting. And is that the quality of the census that's aligned with your programs that makes sense, both fiscally and clinically? Right? So pivoting from volume to value is really important, and using systems that can identify that value so you can make more with less. And think about what that means. If I was able to make the same or more money with, less census, I'm providing better care, the organization is more sustainable, my marketing budget is lower, my cost per admission should go down, right? Like, they all affect each other. And then if I align the admission team's KPIs with the company's net patient revenue, and I'll define that in a second, then I make sure that the admissions decisions that are made are aligned with the company. So net patient revenue to me is the only thing that matters. What I'm owed if I'm a treatment operator, a behavioral health operator, is irrelevant. It's what I get paid. And though there's one patient, there's two customers. I got the insurance company and I have the patient that owe me money. And what I care about is, of those two channels of revenue, what's the average revenue per patient? And if I can align my admissions teams that part of their bonuses and structure is, aligned with the increasing the average net patient revenue for the organization, that's good for the admissions team and that's good for the organization. And part of that is, the money that the patient owes and doing a better job pre-care and engaging the patient. And then think about it. If I'm able to get a patient enrolled and commit to a certain payment program before they even admit, and I have tons of data that shows that that works very efficiently, well, then all that stuff, chaos we talked about for the facility staff and the back office staff, it vaporizes. It doesn't exist. Like, there's nothing to do. It's already been handled. And if I align the admissions team KPIs with those tasks, I'm freeing up all this FTE time, both at the facility and the back office. And then at the end of the day, what it really means is I can grow my EBITDA, not necessarily by adding more admissions, but by me being more efficient and focusing more on quality. Does that make sense?
It seems like every time we have this conversation, that's why I personally love working with FinPays. It seems like a no-brainer that you would want to have a conversation with some. Forget like inducement and customer reviews, alumni, all that stuff. It just seems like a real no-brainer that you would want to be upfront with how much somebody owes and work with them to make a plan so that it's not, because if you're attempting to charge, I guess every day that goes by, and I'm sure you have data on this, Chris, every day that goes by, their likelihood of actually paying or paying less than what they actually owe, trying to make a deal on what they owe, is higher, right? I mean, you got a bill like I get 6 months out, 5 months out, even a month out, you're more likely to question it and call and say, what the hell is this? So
Yeah,
it
let
seems
me,
like a no-brainer that you would want to have that conversation up front, no matter what.
so let me give you some data that's kind of scary. So there's a couple chains of thought. Some people just do nothing. They're dedicated to heads and beds and good luck. Other people say, well, I don't know really what the patient owes, but I ran a verification of benefits and I know what their deductible is. So I'll just tell my team, collect the deductible. So one of the cool things about having a really robust estimator tool in our system that actually before admission will tell you what the patient owes. I can aggregate that data and I can tell our customers some cool stuff. And one of the things is across our network, so we have data on 187 facilities. We've managed about 620 some odd $1 million worth of this risk. And across that whole spectrum, the remaining deductible on all the estimates that were run is only about 28 to 30% of all the money the patient owes. So if an operator said, I'll just go after the deductible, they would be leaving 70% of the money on the table.
Wow.
The other chain of thought that we got some really cool data that tells us. Some people go, well, you know what? I have an outpatient facility and the person, by the time they get to us, they've used up all their benefits. They don't owe us any money. And here's another interesting statistic. So this is August. I looked at it yesterday. Across our entire network, what the patient owed in their estimates was only about 56% of what was remaining in their out-of-pocket max. And the average patient financial responsibility is about $3,200. That $3,200 is across inpatient, outpatient, in-network, out-of-network, like it's a whole blended mix. But what that means is that there is no discount the patient's getting. Yeah, are there individual patients that may have hit their out-of-pocket max by the time they get to? Sure. But you don't run the business on outliers, you run it on the aggregate of the data, right? And at the end of the day, something you just said, I would challenge anybody that's in this business to tell me that as a consumer, that they wouldn't appreciate it if a healthcare provider explained everything to them up front and told them what their costs were and helped them navigate it and understand what they owe and why they owe it. Like, of course, everybody would like that.
Yeah.
The fear factor, the reason it's not a no-brainer is fear of the unknown, Umberto. No one, as we showed in the very beginning, that graph, this problem's only 10 years old, right? Nobody cared if the patient paid. That means there's no subject matter experts. There's no pool of executives out in the market who are patient financial management experts that you can go hire and say, hey, I'm a $10 million company a year. Here's $2 million of my business that comes from the patient. I'm going to hire Jane Doe and Jane's going to run that portfolio for me. Now they hired a revenue cycle manager who handles and manages the claims revenue. And what most of them do, big mistake, is they have the revenue cycle manager also manage the patient financial responsibility. Well, that makes no sense. If I'm a revenue cycle manager and I come in every day and I have 10 priorities for claims and 10 priorities for patient financial responsibility, guess what I'm paying attention to? The claims.
Of course.
So,
because historically that's been where most of the money comes from, and the 25% that is now part of the patient financial responsibility is just written off.
yep. So if I align my organization and I focus on quality over quantity, it's real simple. You align your team's KPIs and motivators to the goal you have. Prepare the patient, be more upfront, be transparent, and make sure you're efficient, time management. So if you can automate those things. Now, Umberto, why, and I know that this is a leading question, but it'll translate. So why is it important for someone to automate the clinical journey with an EMR? Like why, tell me what most of your prospects or customers tell you is their motivator. Why is that important to them?
So automate the clinical journey?
Yeah.
So that they have a standard way of admitting every patient. They're not just kind of, making decisions on the fly.
And then in terms of the charts and everything, how important is that to actually the claims getting coded and paid properly?
Of course. Yeah.
And so automating that, is it fair to say it saves the organization time, money, and chaos?
Of course.
Like, would anybody on this webinar like argue with that point? You think? Would
I
they
don't
say,
think
"Oh
so.
no, that's not true"? Yeah, I don't think so either. So if it makes sense to automate the clinical journey, why wouldn't it make sense to automate the financial experience of the patient?
Yeah, it
Why
seems
would
like we get very organized when the patient is in the facility or they're receiving treatment or care, but this pre-patient or heading bed or patient in the facility is just kind of like however it happens, we'll take it.
Yeah. And then let me ask you this for your business, because you're the CEO. How effective are you going to be in solving a problem in your organization, in your financial model, if you find out 90 days after the fact?
Almost 100% ineffective.
You
I mean,
can't-
as a
There's
company,
literally nothing.
we've had issues with accounting where it's like, just forget about it. We're never gonna, don't even bother going to the customer because they're gonna say, why didn't you tell me about it when it happened, or at least 30 days out, or like right away? Why are we finding out about it now? You can't. Yeah, it's a
So,
write-off.
so quality minded over quantity. See, quantity actually creates more chaos, especially in a business environment where reimbursement rates are coming down, payer audits are going up. It's it's a double negative, and the only solution is automation. I got to be able to take basic manual tasks and make them more efficient so I can actually make more money with fewer patients. And
Yeah.
with growing CPAs and shrinking rates and growing payer audits, everyone I'm talking to, and I talk to, literally 50, 100 CEOs, a month. And I just wrote this article, Umberto, I should probably send it to you, on the one big beautiful bill that was just passed and what it means to
Oh yeah.
behavioral health. If you think this heads and beds problem was a problem yesterday, it's going to get profoundly more complex and complicated, um, because even pure Medicaid operations, they're probably the most vulnerable. Um, there are a lot of changes to the rules that directly impact behavioral health. Some people are under the impression that the carve outs for what they call, necessary services like behavioral health, it relates to the copays, the new copays they put in place. They do not apply to behavioral health, but the work requirements for Medicaid eligibility, right, are 18 to 64-year-olds got to provide work reporting, right? What's the typical age range of a SUD behavioral health patient? And they're not going to be eligible for Medicaid. So now they're going to go over to ACA plans. But what happened to the ACA plans? Right? Well, they removed the subsidies, the extra subsidies from COVID. COVID's not an emergency anymore. So it makes sense that those subsidies were removed, but that doesn't change the fact that, now I have this patient that was used to having Medicaid. Now they're over in ACA. They're getting the bottom feeder plan because it has the lowest premium and it's the subsidy they could get. And so now 30% of your revenue comes from the patient. And now I think I have a really good payer. I'm going to make this up. Oh, Cigna's a great payer. They're great. Get them in the door. Heads and Beds says, get them in. And I'm making that up, that Cigna's the best payer. I'm just using that as an example. In a Heads and Beds model, you're going, get them in. It's Cigna.
Mm-hmm.
But wait a minute. The patient owes 30% of the bill. Doesn't matter that it's Cigna. Cigna's only paying 70% of the freight. I don't know too many places that are running at a 30% profit margin. So this automation is, in my opinion, is critical to create efficiency, right? And
And most of the conversations that I've had around admissions circles around the payer. There's a list of, the most sophisticated companies that don't use an automation or an automated admissions process that's replicable, defensible. They have some version of a payer list that is sort of a priority list of payers that hey, if they, like you said, if it's a Cigna, get them in the door. That's just not the case anymore.
And that's, I'm not going to name the customer, but I have a customer still with me. And the CEO I know really well, and they used to bring me into some of their C-suite meetings because I was like their de facto executive for patient financial management. Um, they're a big, big company. And the CEO used to say, "Oh, we get, $900 a day from, Blue Cross." And I'd pull him aside. I'd say, "You got to stop saying that. You don't get $900 a day. You don't. You're owed $900 a day, but the insurance company only owes 700 of that, and the patient owes 200 of that. So right now, at best, you're getting like 680,
Yeah.
maybe 720, not 900. And if you, as the CEO, go around telling everybody you get $900, your employees start thinking you get $900, and they start thinking, look at all this money we're making. No, that's just what you're owed. And that's in network, right? Like whatever the number is. So it's understanding your revenue streams. What value means, what quality over quantity means, is I'm paying attention to my net patient revenue average. What's the average paid revenue from insurance and patient? And how do I align my organization to focus on that? Because that's what pays the bills. That's what keeps the lights on. So what that means is, not that daily census and occupancy rates go away. They're just the old KPIs. It's not the driver that indicates that the company is going to be sustainable and successful. What matters is, what's my average net patient revenue? What's my insurance plus my patient financial responsibility on average? And then
Paid, not owed.
paid. And then holding your admissions team or giving them an incentive to meet that number or get above it. And so they'll start behaving in the way that goes in that direction. And that's where and then there's outcome tracking, right? I don't have to tell you, you live and breathe and sleep that every day. How do you use your EMR and your efficiencies you've created in it to do a better job of tracking the clinical outcomes? Because, that's the evidence that you're going to use to negotiate better rates from the payers, right?
Yep.
Once again, I can make more money with less. And what's the lifetime value of the patient? If your strategy is you think you're going to send a patient 3 statements, which, by the way, do not count under the inducement laws, and then with no one helping and guiding and navigating on behalf of the patient and explaining and being transparent, doesn't matter how good your clinical care is, the last experience every patient has is financial. And if that alumni relapses, what was your most profitable, easiest to convert, and lowest cost admission is now going to a competitor. Simply because they're I'll use your example, the one that you gave about your wife's recent scenario, right? Like
Yeah.
you're not your annoyance with it, and I'll bet they took care of her clinically. I don't want to reveal what it was,
No,
but
they did a good job. They did a good job. I have nothing to say about the care itself. It was the financial journey that sucked.
And what
Still
did you
does.
talk about? If I didn't ask about the clinical, you wouldn't have
Doesn't
even
matter.
you didn't even bring it up.
Every time we talk about the care, I rave about what they did, but that never comes up because what's hanging over my head is the financial part.
And you want a litmus test? I tell people this all the time. You want to grow your EBITDA by 15% and not add a single new body to your census? Pay attention to your alumni. And I don't mean pay attention by having the pizza party that they come back at. I mean, create an experience for your alumni that makes sure that there's no barriers in the case of a relapse, that they go to anyone else but you. Anyone else but you. And if they have a family member or friend that needs treatment, there's no one else they're recommending but you. And here's the measuring. The typical treatment facility has 12 to 15% of their census as alumni. I have clients that 28 to 32% of their census is alumni. Now, to a novice, they may say, oh, that many alumni, your programs don't work. Well, no, we know the relapse rate in this industry is 60% or more, right? So, but alumni, the CPA is almost zero. They convert at 50% when they call in versus the 5% of a typical admission. And if it's in the same benefit year, they're 25% more profitable. Why would anyone, A, not track it, and B, not, I mean, vaporize any chance of aggravating that patient? And that's why I say if you use technology to engage the patient about cost up front, here's what they remember. Man, I was scared. I knew I had money. I didn't know what it was. They made it easy for me. And they helped me the whole way. And there's technology. And yes, I'm being biased. FinPay has technology that does this. But I'll say to you, find something, right, that automates that lets you engage patients up front and using electronic financial records to automate that. Because, I mean, in this one conversation we've been having in 45 minutes, we've talked about how it improves your EBITDA, it lowers stress on your teams, right? It gives you better visibility into where your revenue is coming from. You don't need to be a slave to census in your marketing budget. I mean, I can't believe CEOs aren't just exhausted over the anxiety that they feel from there's no real correlation between the marketing strategy, marketing budget, and what the census fluctuations are on every month. And no one can really say why that happens. Well, you want that to stop? Stop playing the quality game. I mean, the quantity game and get into the quality game. Right? And that's just my view. And a great timing, great transition. So we have a new customer. I just want to give some data around it because I think it'd be helpful. So we have a new customer, has a inpatient and outpatient programs. And it's a sizable business. And they were collecting, I'm looking at the screen right now, about $13,000 a month in patient financial responsibility. In the very first month using electronic financial records, they generated 24,000. The second month, 110,000, and they're on track for 130,000 this month in the first 3 months. And the trajectory is just going to keep going, right? The average collection rate of patient financial responsibility is about 15% in the behavioral health industry. And that means you're not getting paid 85%. So that means there's that many other like additional admissions you need to generate the same amount of cash. But if I'm actually paying attention to that revenue stream and I'm managing it just like I manage my claims revenue with automation and KPIs and I have visibility into it, well, wait a minute. If I actually got that money, I don't need as many admissions because I'm making more money with less census. And if I hit the same census, now I'm really making more money and the business is even more sustainable. Quality over quantity in this market. Watch the winners. I'll put the stake in the ground right now. The companies that focus on quality of census over quantity in the next 36 months are going to be the organizations that are, gobbling up all the small failing businesses that have just been unwilling to change and ignore the fear of the unknown. That you said it seemed like a no-brainer earlier. That's the barrier.
And we're kind of already seeing that sort of M&A activity with some of the players that are data driven and that are using technology automation to ensure that the patient journey from the very first time they make a call through care and billing is seamless. We have a customer in common. We're not going to mention the name, but they're very good at that. And they're going out buying a bunch of facilities because they have sort of a blueprint that uses FinPay and Opus and other technologies to ensure that they have this down to a science.
I'll tell you another one that's pretty interesting. So we have a big client that's been with us, for months, not years. And unbeknownst to me, like we have a pipeline of prospects and I'm talking to this smaller organization about hiring us. And all of a sudden they're like all excited to hire us. And then they went black on us. Like you couldn't get the CEO on the phone. So last month I get a call. I call up, the CEO answers the phone. I said, "Hey, what's going on, man? You were telling me you wanted to rush in, but He said, well, I couldn't tell you, but we were recently acquired and we had a dark period. We weren't allowed to do anything differently for 69 days. And I said, oh, that's great. Who bought you? They mentioned the name and it's a customer of mine. So I called that customer and he said, I kid you not, he said, Chris, one of the reasons that made this deal attractive, what we learned from you guys, we actually made it in our due diligence when we were looking to buy this company. We realized, holy cow, they don't even realize how much cash is in their own business.
Mhm.
We literally bought I'm going to make up these numbers to prove the point. The company was, they were cash flowing $1 million a year, and we paid 5 times, EBITDA. But we figured out there was another $400,000 in EBITDA in there. They just didn't know about it because they couldn't see it. And they never collected it. They never paid attention to it. So we literally just added 40% of value of this product, this asset we just bought in 60 days.
Use their own numbers against them.
Because they knew when you have visibility, you could go in and look at another organization and go, oh my God, they're not even paying attention to that money. I can buy it on the cheap.
Yeah.
Where if you're a seller and you go, holy cow, look how much more money I can make if I try to sell this business. If I got that money I was owed, I could, grow my EBITDA by 20, 30% and not add a single new body to my census.
Yeah, and I think another reason it's a no-brainer is because you talked about the customer that had been with you guys a few months. They were collecting 13,000, 24,000, 100 and something thousand. Now they're on track to do 150, I think you said. The technology pays for itself. It's not like you're going to be, you're going to be upside down on this to collect a little more money. I mean, this is significant revenue we're talking about. So it's just another reason it's no-brainer.
Yeah. So I guess should we leave some time, give some people a chance to ask some questions? Sean, how do you want to do that?
Yeah, we can actually, I know we've got 10 minutes left, but we can take questions after the fact as well, just because I know we've
Gotcha.
got a few more things to go, and I don't know if we'll have any questions come through by the end.
Yeah, and by the way, if anyone is interested in that article I wrote about the One Big Beautiful Bill and those policy and payer shifts and what it means, just reach out to Sean or email Sean, and I'll make sure we get it out to you. It should be an interesting read. It's very timely. It has material impact on the business. The other reason I think this really matters now is all the things we talked about is putting economic pressure to be more efficient, right? The more the companies that can deliver care in a cost-efficient manner are the ones that are going to thrive. I also, just common sense, kind of what, Umberto, to your story, there's a big trust gap between providers and patients when it comes to costs. I believe the organizations that capitalize on that mistrust of everybody else, but create trust for your organization are going to be winners. And because patients aren't stupid, it's the age of Google and ChatGPT. They can research cost for care way in advance. And unfortunately, most of them are still misinformed, right? Their research is giving them misinformation. And so being the organization that, has access to the real cost and can explain it and navigate, explain insurance, explain the billing and claims process, explain ways they can save money with, FSAs and HRAs and all the other ways that they can reduce their spend. These are the organizations that are going to win because they're going to win the hearts and trust of the patient. They're going to show that they're providing better outcomes at lower costs, so the payers will love them, and that's who's going to win. So, what can we do about it? Well, we talked about a lot of it. Embrace automation, data and transparency. You can't fix a problem you can't see. The patient's experience clinically and financially is everything. Everything, everything. We talked about alumni, right? We talked about, we didn't get into lengths of stay, but patients that are engaged, so here's the math. Patients that are engaged around cost before they're admitted and financially cleared before they're admitted, they stay 3.1 days longer for inpatient and 3.05 days longer for inpatient and 5.1 billable days longer for outpatient. You could start measuring quality both clinically and financially, and it's not hard to do. And if you have a CRM or an EMR that doesn't allow you to do it, switch. Right? Like visibility is everything. And then kind of the whole theme of this discussion, the head to bed strategy is expensive, it's inefficient, and it's a dead model that will kill a business in 3 years. And I'd love someone to disagree with me and tell me why I'm wrong, because it'd be great if I was wrong, but I don't think I am. And so I love this line. Sean came up with this one, I think. I like it. Quality is the currency of tomorrow. And the question you have to ask yourself is, I don't know the people that are on here, what role you play in your organizations. Are you in leadership roles or management roles? But you have to ask yourself, is my organization ready? Am I ready for a transition to quality from quantity? And if we're not, what can we do about it and what should we do about it?
Love that. Thanks again, Chris, for your time. Obviously, Umberto, this has been a great discussion. In closing, as always, I'm sending this recording out to everybody. I don't think we'll get any Q&A before the end of the call, but feel free to email me. I'm going to pull up a screen right now that's got an email. If you want to reach out to Umberto or Chris directly, you can reach out to them with the emails here. Obviously, you could call us, check out our websites, but open discussion to anybody who sees this. If you have any questions about the topics discussed or anything technologically related in regards to your organization, yeah, we'd love to chat. So,
and by the way, that article I mentioned about the one big beautiful bill, if you don't want to email Sean and wait for us to get back to you, if you go to finpay.com, that website, under the resource section, the blog, the articles are there, and you can see if you just want to go to it and look at it. I do think it's very timely and it's extremely relevant what's going on. If nothing else, the article might make you do research on your own and research other people that are weighing in on the topic. I'm not suggesting just because I wrote it, that means I'm right. It's thought provoking, and it should make you want to do more research.
love that. Obviously, the industry is shifting so quickly. Keeping up with the times is super important. And like Chris said, this is very timely. Like, these are the things happening right now. Thanks again, everybody who attended. And Umberto, Chris, thanks so much for your time. I know you guys are super busy, but I think this is super beneficial for our audience. But yeah.
Always a great time when
thank you.
we got on the video with Chris.
It was a lot of fun. It was a lot of fun. And there's a lot of moving pieces and it's complex, but solving it is, part of the intellectual rush, right?
100%.
Just, being the organizations that are solving these problems, getting ahead of them, and being the leaders in the space. And, I love working with organizations that are forward thinking. So
Yeah.
thanks, guys.
Of course.
Yep.
Chris, I'll go ahead and stop the recording, but